name's Kristin Twidwell. I am the PA that works with Dr. Chatwell. I see some familiar faces, some not. But thanks for coming. The whole purpose of these knowledge nights, we do them once a month, and each provider will spend some time talking on a topic. And the whole purpose is just to empower you to have knowledge on what's going on with your body. So that way when you go to the doctors, you know the questions to ask, and you know what to look for, and you kind of understand what's happening. Why is it black?
Give it a second.
Give it a second, guys. There we go. All right. So tonight we're going to talk about Dexa, and you know, I didn't really think about it till later when they made this title. It's a little misleading because I had a patient just the other day ask me when he saw the flyer, well, what's a Dexa? If you don't even know, you may have no idea what you're here to talk about tonight. But essentially that is a bone density scan. So over the next 30, 45 minutes, that's what we're going to talk about. By the end of this, I want you to be able to read and interpret your own bone density, so that when your doctor calls you and said, hey, your bone density looks good, you can say, wait a minute, what are my T-scores? What's my FRAX score? What's my T-score compared to last year? Am I maintaining? What's my Z-score? You know those questions to ask. So we'll talk about what a bone density is, who needs a bone density, how often. We're not going to dive into osteoporosis and treatment, but if you have questions, I mean, I'm happy to answer those. So we'll just kind of see where it takes us. So this, just out of curiosity, who's had a bone density?
You did.
I was about to say, you have. So this is what a bone density looks like. And it's a very painless test. You just go, you lay on the table, this little arm kind of moves, and then that's about it. It's really easy. But essentially it is a test used to determine your bone strength or your bone quality, and we use this to diagnose osteoporosis, which is weakening of the bone, right? And then we use it to predict your fracture risk. What are the risk of you breaking a bone? Because that's really what this is all about. And then we use it to monitor therapy. If I stick you on some medicine for osteoporosis, I need to know if it's working. If it's not working, then I would change you to something else, right? So this is how we keep an eye on that. Now this is something that can be confusing because it's called a million different things. There's Dexas, there's BMDs, there's sometimes we see it listed as a QDR. So when your doctor says, hey, I'm going to set you up for a BMD, or I'm going to set you up for a bone density or a Dexa, they're talking all the same thing. Wait for it. There we go. So who needs a bone density? So technically, the official suggestion is, first we'll talk about women. So women 65 years of age or older. This used to be, when I got out of school, and that, I mean, a decade ago, it was 50. I mean, they've really kind of shoved it back. I'm sure insurance has something to do with that. But 65 years of age or older, in postmenopausal women that are younger than 65 years of age, if they have clinical risk factors for a fracture, which we'll go over, what does that mean? Basically, if you are at a high risk for a fracture and you're under 65, I can still order a bone density on you. I just have to essentially prove why I'm doing that. And again, we'll look at that list in a second. Now men, it gets a little bit more confusing. Basically, we don't have a strict guideline like the magic number of 65, only because there isn't a lot of testing that has been done. It doesn't mean that men don't need bone densities, it just means I don't have a lot of data to back up that magic age where I determine you need one. So basically what we say is that if you are at a high risk for fracture, and again, we'll go over this whole laundry list of things. If you're at a high risk for fracture, I'm probably gonna get a bone density on you. So this is the list. So when I meet with the patient, these are the things that I'm kind of clicking through in my head, because this puts you at an increased risk for getting a broken bone. Advancing age, that's the nice way of saying you're getting older. So 65 or older is the magic number there. If you've had a previous fracture. Now here's one thing that I hear patients say a lot. You know, have you ever fractured anything? Oh no, but I did break my arm once. That's the same thing. So if you broke a bone or you fractured it, it's the same thing. Now when I ask you if you've had a previous fracture, I'm looking for what I call a fragility fracture, meaning you probably shouldn't have broken that bone if you had nice strong bones. If you get in a car accident and you break your leg, or you fall out of a tree, or in a patient today who fell off of a ladder, they earned those fractures, right? Anybody, whether you have osteoporosis or not, you earned that fracture. But if I slip on the ice, I'm probably not going to break my hip. If an 89-year-old slips on the ice, they're at a higher risk for breaking their hip. That's a fragility fracture. So that's what we're asking for there. Glucocorticoid therapy, what's that? Steroids. So if you have been put on steroids, prednisone is a type of steroid that we use pretty often in our clinic, and you've been on it for an extended amount of time, we know that steroids weaken the bone. Now there's a difference between I was put on 2.5 milligrams of steroids or I was put on 60, right? So that's something that we keep in mind, but we have to remember that with a lot of our rheumatoid arthritis patients. We use a little bit of prednisone, and that puts them at an increased risk for osteoporosis, and we have to remember that when we're doing treatment. Parental history of a hip fracture, what does that mean? Mom or dad. If mom or dad broke a hip, we know, statistically speaking, you are at a higher risk of breaking a hip. I do. I care about your aunt and your grandma and your sister Sue and all of that, but really, for this risk factor, it's just mom or dad, did they break a hip?
Can I ask a quick question?
Yeah.
About the steroid prednisone use. Is there, why do you always, I won't say always, but typically use prednisone for rheumatoid?
Sure. So typically when a patient comes into our office and they're first diagnosed, that's the first medicine we start. Why? Because it's going to kick in by tomorrow, and it's going to get that inflammation to slow down, and it's going to make you feel better. You're going to have less swelling, and have range of motion, and then I don't have to worry about those erosions forming in your joints.
Understand that.
It's also the first medicine that we stop. So we may put you on prednisone while I also put you on something else that's going to take 2 months to kick in. And then as soon as that other medicine kicks in, I'm pulling you off of prednisone. Does that answer your question?
Well, yeah, I'm down to 2.5
Yeah.
a day, and I guess based on what I hear about prednisone, etc., I would like to get down to 0.
Sure.
But
That's
I know
always my goal for my
it's
patients.
about 1.5 years, 2 years.
Yeah. Yeah, it's always the
Still
goal
on.
to get you off. But I will say,
There is a good chance, or a fair chance, that I could get off of that medication.
Yeah.
So, okay.
yeah, absolutely. No, we don't expect, if you have rheumatoid arthritis, I don't expect you to be on prednisone forever by any means. No, it just means maybe your other medicine needs to be amped up. Now, the other thing is, though, and every patient is different, I have some of my rheumatoids who are on 2.5 milligrams of prednisone. And you know what? The potential benefit far outweighs the potential risks. Meaning, I'm okay with them staying on 2.5. I'm not okay with them staying on 10, because that is going to increase the side effects associated with steroids. So, but yes, the goal is always to get you off of prednisone. Low body weight. So this is my little tiny old ladies, my 85-year-old, 90-year-old little lady. I'm worried about her bones. Current cigarette smoking. We know that if you smoke, that increases your risk for osteoporosis. Excessive alcohol consumption, greater than 3 drinks daily. Rheumatoid arthritis. Just having rheumatoid arthritis alone increases your risk for osteoporosis. So a lot of times as we sit here and we talk about when should we screen men with a bone density, guess what? If you have rheumatoid arthritis, you're on my list. You know, you got a clinical risk factor, and I have you on prednisone for 10 years, and you're a smoker, I'm probably going to order a bone density on you. Secondary osteoporosis. So this is when there's something else going on, like you have an inflammatory bowel disease, or you're not absorbing some of your nutrients, or you're spilling calcium into your urine, or you're having some endocrine issues. So something else is going on, and therefore your bones are not building as strong. Early menopause is another reason. We know that obviously with women, you know, their ovaries aren't shooting out the estrogen to keep their bones strong. So these are all reasons, and we'll sit here and you'll hear that phrase come up, those clinical risk factors for fracture, and that's the list that you always want to keep in mind. So really what we want to know is, that's fine, Kristin, you want to order a bone density on me, but is my insurance going to cover it? I mean, isn't that unfortunately what it always comes down to? So Insurance goes by, and we talk about Medicare. Medicare goes by that rule of the 65, or if I can show them those risk factors, why do I want to order this, then I've never had any problems with insurance denying me. And again, men with significant risk factors. I asked our business office, I was just kind of curious, if I had a patient and I wanted to do a bone density and for whatever reason their insurance said no, what would that cost out of pocket? And Linda said it's about $50. So not a super expensive test. It's not like ordering an MRI or something like that. So that's something to consider. I don't know why, if you really needed a bone density, your insurance would say no, but that's always an option if you wanted to pay out of pocket. Okay, this is, when I come up with these talks, I sit down and think about what do I talk to my patients about every single day. And I say every day I'm at least going over a couple bone densities. And this is a conversation that I have every single time, usually with new patients. We want you to stick with the same machine. So what does that mean? And there's a whole, that is just a lot of verbiage right there. But the reason I threw that in is because for whatever reason, people really like to argue with me about this as if I'm just trying to make your life difficult. I'm not trying to be mean and tell you have to go back to Brian and do it over there or AMI, but each machine is a little bit different. And if I'm sitting here trying to compare, well, how were your scores 2 years ago? And is the Prolia helping you? I want to compare T-score to T-score down to like the 10th, right? And if you are bouncing around on different machines, we can't compare that because of these reasons. So the reason I put all that verbiage in there is so people don't think I'm just making this up. This is actually legitimate. There's different technologies, there's different methods, there's different mathematical calculation, there's photon beams coming in from different configurations. And essentially, if we want to be able to compare one test from the other, I need it to be on the same machine. Now, I'll have people come in and, okay, your last bone density was 5 years ago, where was it at? Oh gosh, that's when I lived in Wyoming. Well, I'm not gonna send you back to Wyoming, let's start doing them here, right? And then from now on, you'll just do them here. But if you have one done locally, of course I would love you to have the ease of just doing it in my office, because then I know where you're at and I can see the report. But if you've done one locally, I would prefer you just keep doing it on the same machine.
And when you say same machine,
Yeah.
we're talking about same manufacturer and everything. There's
Literally.
4 machines in this room. You gotta go to number 3 every time?
Sure, so we have, that's a really good question. We have one machine, and I would say most places probably don't have, it's not like they have 27 bone densities lined up, right? So the other thing is, say I've had some people, this happened with one lady, they got a new bone density in her hometown. And so it was one of those, well, it's not the same machine, but here's your chance. Do you want to reset here? Do you want to just get it taken care of in Lincoln, or do you want to keep going back there? But literally, I want you on the same machine. Yeah. Okay, so this is a lot of verbiage, and we're gonna break it all down piece by piece. But essentially, when I send you to get a bone density, and what I love about doing bone densities in our office is it's all under our roof. You're gonna go get a bone density, and then you're gonna do your labs, and then you're gonna go back in the room, and then I'm gonna come in and I'm gonna, boom, I'm already gonna have the report in front of me. And this is what it looks like. Now, every machine's report looks a little different. When I see bone densities from other offices, I kind of have to get my sea legs under me. I have to figure out where everything is because it's just configured a little differently. But this is essentially what your doctor or PA or nurse practitioner is going to go over with you. And the thing is, by the end of this night, you're gonna understand what all of this means. So instead of the doctor staring at the computer screen and saying, Joe, your bones look great, and then moving on to something else, you can say, hey, do you mind, can I take a look at that? Pull that screen around. I move my screen around and I show this to my patients so that they can see it. So what do we check? Essentially, we are checking clinically relevant sites, meaning I cannot scan you head to toe and figure out the bone density of every bone in your body. So we have to pick the sites that are most important, meaning if you break them, that's going to cause you more problems. So we check typically 3 different spots. The AP spine is your low back, it's your lumbar spine, so right down through here. Why do we check that? Couple of reasons. We know there's greater bone loss here for women that are early menopause. So if you're gonna start losing bone, you're gonna start losing that bone density in the low back. So we're gonna keep an eye on that. This is also considered one of the best skeletal sites to monitor because it shows less variability and can detect responses to therapy earlier. What does that mean? Basically it means, hey, this is a great way to monitor your response to treatment. If I do a bone density on you and you have osteoporosis and I put you on whatever, Fosamax, and then 2 years later we're rechecking it, I'm wanting to see what are those scores, and this is one of the first spots that are going to start showing some changes is in the spine. So that's a great spot for me to keep an eye on if your scores are maintaining, getting worse, getting better. The other two spots I kind of put together, 2 and 3, is because it's the hip. So I call it the fem neck or the femoral neck. That's basically the skinniest part of the hip. So if this is the hip joint, right? This is the neck of the hip, right? Skinniest part. The total femur is this whole thing, that whole part of the hip. So why the hip? Well, everybody knows if you get a hip fracture, it's not good, right? It's kind of a downward spiral. You gotta be admitted, you gotta have surgery, and then you gotta stay in the hospital and you get physical therapy. And by the way, when you're in the hospital, you got pneumonia, and then you gotta, it's one thing after another. One of the numbers I found, and I think these numbers are actually pretty old, the estimated cost for a hip fracture, $81,300. Holy Moses, most of that, half of that was just from facilities, meaning the hospital, and then having to stay in-house physical therapy and all of that. So we know that a hip fracture is associated with significant morbidity and mortality. Morbidity, mortality, meaning it's going to cost you a lot of money. It's hard to recover, and guess what? There's a higher risk of death associated with a hip fracture. So we're going to keep a close eye on those scores. And the bone density of the hip, the Dexa of the hip, is generally regarded as the best site for the diagnosis of osteoporosis. So that's definitely an area that we keep an eye on. Now, this is traditionally, these are the 3 spots. There are times where we will check the forearm, which is right in here. Reasons that we would do that. Say you have bilateral hip replacement. Well, I can't check the bone density in your titanium hip, right? So we would do a back, and then we would do a forearm. Or say you have horrible osteoarthritis of the back. Or like I had a lady the other day and she has really bad scoliosis, and she's got that S curvature, and it's really hard for them to get calculations of all the 4 vertebrae that they're looking for in the lumbar spine, so they'll have to toss that out and they'll do a forearm instead. So don't be surprised if you're looking over your bone density and wait a minute, Kristin said you were going to check my hip and my back, and they checked a forearm score on you. Okay, so what is it that they're calculating? I keep saying the word T-score. So essentially, your T-score tells you either you have normal bone. If you're above -1, you're good, you're in the green. Once you go and you hop over the fence and you're below -1, all of a sudden you have osteopenia. So what's that? That's just weakening of the bone. Not full-fledged osteoporosis, but hey, your bone's getting a little bit weaker. Once your T-score drops all the way below -2.5, now you're in the red, that's osteoporosis, okay? So when we look over the bone densities together, because we're going to, I'm going to show you some different examples, and you're going to tell me what this patient has based off of their T-scores.
Typically with this range, do you not require any treatment until you get into the red?
That's what we're going to talk about.
Okay.
So some people require, or it's recommended, treatment in the yellow.
Right.
So I know you're excited. I can tell. You're getting ahead of yourself. Okay, so that's all good and dandy, but what does that really mean? I thought this top chart was really interesting because quite honestly, how many bone densities have I ever gone over? And I never really stumbled across this, and it really kind of gave me a good visualization. So if you have a T-score of -1, we just talked about, that's osteopenia, right? You just fell into osteopenia. You've essentially lost 10% of the density of your bone, okay? A couple years later, you come back and, oh man, now it's a lot weaker. You have a T-score of -2.5. You now have osteoporosis. You have lost 25% of the density of your bone. If you're down here, I think I've had one patient that was a minus 4.3. That's bad, by the way. But if you're down here, minus 4, you've lost 40% of the bone density. So this over here is a healthy bone. I think of the bone, it kind of looks like a spider web, like a matrix. I mean, that's how you build a strong building, right? That's not going to crumble. But as you start losing your bone density, you get kind of that honeycomb appearance, like over here to the far right. That's probably like a minus 4.0 right there. But you can see how that would break a lot easier, right? If that falls. So that is basically what we're trying to prevent. The other thing, and I don't really have a spot right through this end, but something to consider is this is kind of the nature of the beast, right? Like our bones are going to lose a little density as we get older and older. What we're trying to do is slow that down. So typically, once you get, down to a minus 2.0, it's an uphill battle to build your T-score. So that's when you have to start paying attention. You don't want to wait until you're way down here. You want to try to preserve what you have. Okay, so this was on that paper, but this is on the first page. And when I'm reviewing a bone density with patients, this is what I pull up and I say, really, everything, well, not everything, but a lot of what you need to know is in this little square right here. But first we'll start over here. So what sides did we check? AP spine, right? So lumbar, usually it's lumbar 1, 2, 3, and 4. This patient probably had a crummy L1, meaning maybe a lot of osteoarthritis, so it got tossed out. So we only got L2, 3, and 4 on that patient. The left femur neck, so that's that fem neck, right? Now why the left side? How do we pick and choose left and right? Whoever is doing your bone density is going to ask you, are you left or right-handed? If you're right-handed, your right side is your dominant side, and that is stronger. This is going to be your stronger hip. We want to know the weakest of your bone. So we're going to go over to the left side. So that's how they determine if they do left or right. Now, if you have a hip replacement, obviously we just got to go with the other side, okay? So there's the neck of the hip, there's the total hip. Okay, we're going to skip over here. We'll talk about that Z-score in a second. Basically, the answer to your test is right here. So the classification, they tell you normal, osteopenia, normal. But here's the T-scores. This is something else I want you to take away. And I don't know how other doctors' offices do it. I review my bone densities with my patients in front of me so they can ask me questions. Most doctors' offices, the doctor reviews it and then the nurse is going to call you. And the nurse is going to call and say, hey, your bone's normal. Hey, you have osteopenia. Everything looks good. Now you can ask, oh, okay, that's fine. I know I have osteopenia, but what's my T-score? Because there's a difference between an osteopenia of -1 and an osteopenia of -2.4, right? So now you're able to discuss that with your doctor. So like this patient, their back looks great. They have a positive 1.8. That's a super great back. Their fem neck is a -1.5. Remember, anything under -1 is osteopenia, okay? Their total hip is a -0.7. That's above -1. So they still have a normal hip, okay? Okay, so what is a Z-score if you, right, that guy right there, Z-score. Basically, a Z-score is a comparison of the patient's bone density to an age-matched population, meaning, a white female who's 36, that would be a Z-score. You're comparing me to other white females who are 36. You're comparing me to other African-American males who are 85 years old, right? This is used, when do we use the Z-score? This is used when we do a bone density on children, premenopausal women, or men under 50. Because remember, those are not the people that technically are due for a bone density, so this would be special circumstances. T-scores don't really apply to them. How they're calculated, that's not going to help them, so they're going to live at a Z-score. Now, how do I use it for my patients? I keep an eye on it because if I see a Z-score that's less than -2.0, this is below the expected age range, and then I have to start thinking, okay, why are your bones so much weaker than another 75-year-old? And then I have to start thinking about what are other reasons that can cause that? And anytime you go in and you're getting a bone density, your doctor, we're already thinking about that. oh, we better check a vitamin D on this patient, and how's their serum calcium, and should I check a calcium in their urine? And so those wheels are already turning. But if I see a Z-score of less than a minus 2.0, I'm probably going to do a little extra testing on you. How's your parathyroid hormone? You know, what's going on? Are you having any GI problems, like you have an inflammatory bowel disease and you're not absorbing your calcium? So it just makes us think outside the box a little bit. Okay, so this is something that honestly, until I came to work here about 4 years ago, I had no idea what it was. And I don't think on our bone densities that we ever calculated them in my family practice office. So a FRAX score, it is basically a mathematical calculation that says, okay, what are the odds that I'm gonna break a bone in the next 10 years? And what it does is it takes like your T-scores, it takes your family history, are you a smoker, do you have rheumatoid arthritis, you know, all those risk factors, it takes all of that, and then it spits out this statistic. Now it is just that, right? It's not a magic ball. It's not gonna tell us for sure if you're gonna break a bone, but it just gives me an idea of, okay, you know what, you have a higher FRAX score than I'm comfortable with, so we need to keep an eye on you, okay? And essentially what it does is it calculates a score specifically for your hip, because we are really concerned about the hip. So I get a score for your hip, and then I get a score for what we call like an overall fracture of major bones. Major bones include the spine, like a compression fracture, your hip again, your forearm, and your shoulder. So you were asking about, you know, do we not have to worry about treatment until we're in the red? Well, some people that are in the yellow, osteopenia, but they have a high FRAX score, we go ahead and we start them on treatment. We try to be a little proactive. So this essentially is the golden key. If you have a 10-year risk of an overall fracture, that's hip, back, shoulder, forearm score, that overall fracture that's greater than 20%, I would consider you at high risk, okay? If you have a hip fracture score of greater than 3%, you're at high risk. This is what that looks like. This is always the back page, the last page that I get to with my patients, and I twirl this around and I show them. So this is the fem neck that we were just talking about, right? The skinniest part of the hip. This is the total hip, okay? There are limitations to the FRAX score that they do need to fine tune, and one of them is the fact that when they are calculating it, they use the T-scores only from the hip. They don't use the T-scores from your back, or if we did a forearm. So I may have a patient who has a horrible T-score of her forearm, but her hip looks great. So her FRAX score looks great, and that's very misleading. But for the most part, this is a really useful tool. So for this patient, the risk of them breaking a major osteoporotic fracture in the next 10 years, 22.2%. That's a little bit higher than I would want. The risk of them breaking a hip, 5.1%. That's much higher than I would want. So they are considered at an increased risk, or they have what we say an elevated FRAX score. And that can be a game changer when we're talking about, do we treat you or do we not? Okay, so before we start looking at bone densities, a couple other things. This is another question. Dexa, how often should I get it? Not everything in medicine is black and white, which can be really frustrating at times, and this is one of those things that's not black and white. So I'm going to give you kind of a breakdown, but if your doctor says something different, don't stomp your feet and say, well, Kristin said 3 to 5 years. Ask them, because there's logic going on up here that they don't always verbalize. If you have osteoporosis, typically we repeat your bone density every 2 years, okay? Now, if I have a patient who has been on multiple medicines and I have them on my last ditch medicine and their scores are pretty stable, I'm okay with stretching that bone density out, because realistically, what else am I gonna do? You know, if I get a bone density back and your scores don't look great, I'm not gonna change your treatment. So we'll spread those out. But typically, every 2 years we're doing a bone density. Now, what if you have osteopenia, you're in the yellow, with risk factors, meaning the family history of the broken hip, I'm a smoker, I'm underweight, I have rheumatoid arthritis, and I'm on 60 milligrams of prednisone. I'm gonna get a bone density on you every 2 years, okay? If you have osteopenia without the risk factors, your bones are a little weak, but I don't see any other indication where I'm kind of concerned. I would spread you out to every 3 to 5 years. And the reason for that is because it takes a long time to lose that bone density and your scores start to fall. For example, I just had someone in my office and he's osteopenic with a low FRAX score, meaning he has osteopenia, but his T-score, his worst T-score was like a -1.1. He's barely osteopenic. And his FRAX score is low, and I mean, he's doing really well. If I recheck his bone density in 2 years, he's still gonna be osteopenic. Still gonna be osteopenic. He's got a long way to fall before he hops over the fence into osteoporosis, and then I have to start talking to him about prescription treatment. So we can space that out 3 to 5 years. This one, when I was putting together this talk, honestly, this kind of surprised me. If you have a normal skin or slightly low with no risk factors, they said, whoever they is, every 10 to 15 years, you could wait a whole 10 to 15 years before repeating your bone density. And I get their logic because, again, it takes a long time for your scores to fall from the green through the yellow into the red. But I don't know if I would feel comfortable with that. And actually, I offered it to a patient the other day because I just put together this talk because I was on top of things. And I said, well, your scores look really good. Technically, we can wait 10 or 15 years. And she kind of looked at me and she was like, I don't think so. So we compromised on 5. So don't, again, your doctor may have a different plan for you, but this is kind of the general recommendations. Okay, let's look at a bone density. So when your doctor pushes this around, this is all the information that you see on it. Up here is going to be your information. These here are the indications, all the different reasons that I'm worried about you having osteoporosis, okay? So if, like, here's somebody, rheumatoid arthritis, they have vitamin D deficiency, they're postmenopausal, they have a history of a fracture. Over here, we specifically will list the fracture of the foot. Talks about different treatments they're on. Now, these can be treatments that can help the bones, and they can also be treatments that we know can lead to more bone turnover, but they'll list all of those over here. And then comes, the meat and potatoes. So we checked the AP spine. We got a whole L1 through 4, so that's good. This is a right-handed person, so we got the left fem neck, the left total femur. We're gonna hop over here. Their Z-scores are fine. And we're gonna go over to their T-scores. So you got a -1.6, -2.1, and a -1.8. So based off of just the T-scores, what would you diagnose them with? Okay. Okay. Ding ding, you get your medical degree. Okay, so they're osteopenic in all 3 areas. The weakest is the neck of their hip, but yeah, so they're osteopenic. So then the next thing that we're gonna look at is, okay, you're in the yellow. What's your FRAX score, right? Because that's gonna determine whether or not we need to talk about calcium, vitamin D, weight-bearing exercise, or if we need to actually put you on a prescription. So we'll get to that in a second. This is the second page. And everyone learns a little differently. I think some people do well when I show them that little triangle and I show them their scores. I think some people like a visualization. Here you are, you're in the yellow, but you're on the upper end of yellow. Or, sometimes I can show them this is where you were. Like, this is where you were in 2014. This is nice. We can look back really easily. You were a -1.8. Today you're a -1.6. So you're going in the right direction. You're building stronger bone. Again, can give you a visualization. Sometimes if I can see that patients are kind of hesitant to proceed with treatment, if I whip this around and I show them how they're hanging out in the red, that usually catches their attention a little bit. So there's all different ways to kind of visualize what's happening here. There's this person, the neck of their hip, they were a -2.1 2 years ago, -2.1 today. I call that a win, because if I can stabilize your bones, we're doing pretty good. You haven't lost anything. -1.7 down to a -1.8. So their total hip dropped a little bit. All right, where's the FRAX? There's the FRAX. Okay. Risk of major osteoporotic fracture, 33.7. So what was that magic number we wanted that under? Do you remember?
20.
Nice shot. So that is too high, right? And then their hip fracture is a 6.9%, and the magic number for that is 3. Yeah, that other patient was 5, you're right, but we were aiming for 3. So the final diagnosis would be osteopenia with an elevated FRAX score. And that is why that FRAX score is so important, because that's a game changer. If your doctor had just called you and said, hey, Carol, we got your bone density back and you're osteopenic and we'll see you in 2 years. Okay, great, but what's my FRAX score? Because that determines whether or not I should be on treatment. And I've had patients come to me and say that, hey, when was your last bone density? Oh, I just did it last month at Dr. So-and-so's, and I have osteopenia. Okay, so what's your FRAX score? Well, I don't know, did they calculate it? And I've pulled bone densities from other offices and reviewed them with patients and they didn't calculate a FRAX score. That's not always the case, but sometimes they don't. So I'll turn around and calculate it myself. All of a sudden, we're having a full conversation about, hey, you're at a high risk for a fracture, and technically, I'm supposed to be offering you prescription treatment. So then we kind of talk about that. It doesn't mean you have to take treatment, right? Our job is just to educate you and give you options, but you are considered a high risk for a fracture, which is what we're trying to avoid. All right, so here's another one. This is another female. Let's see, what does she got? She's got a family history, so mom or dad broke a hip. That's a ding against her. She has had a compression fracture. That's a break in the spine. That's not going to help her FRAX score. Low body weight. There's another risk factor, right? Postmenopausal. It's not her fault, but it is a risk factor. And then, of course, it talks about her treatment. Look at that. She's on Prolia. So she's already being treated for something. Okay, we come down here, we checked her spine, we checked the left neck of the hip, the left total hip. So when you look at this, where's her problem? Can you see that? Her AP spine is a minus 2.8, her hip neck is a 0, and her total hip is a 0. So where's her weak spot? Yeah, in her back, which makes it right, which is probably why she has a fracture in her back. So what's her formal diagnosis based off of that T-score? Minus 2.8. Do you remember what number it is where you hop over the fence?
Minus 2.5.
Good, minus 2.5. So she is below that. Here's minus 2.5. Here's her. So she's got osteoporosis.
And would you say she just has osteoporosis in her spine, or?
Sure, yeah, you can definitely specify that. You have osteoporosis of the spine. Now, realistically, if she has osteoporosis of her spine, she probably has it in other parts of her body, right? Because we can't check the whole thing. When I use, when I put her official diagnosis in her chart, we don't specify where the osteoporosis is at. Either you're an M80 1.0 or you're not. M80 1.0 is osteoporosis or you're not. But yes, when you're talking to a patient, yeah, you can specify you have osteoporosis of the spine. And I'll do that because then I have to remind them, your spine is really weak. This winter, I don't want you shoveling snow, right? I don't want you lifting over, 10 pounds. Those simple things, that twisting is how you can get a fracture. And again, here's a nice way to visualize it. She's in the red. I mean, there's that little dot right there. That's her. But the good news is, if you guys can see this, 2013, her score was a minus 3.4. So while the minus 2.8 doesn't look great, it sure looks a lot better than 2013. So she is going in the right direction. Her hips are strangely strong. I mean, a 0, that's pretty good. So she's got good bone density at the hips. Okay. Usually, when somebody has osteoporosis, they have a T-score for osteoporosis, we don't bother calculating a FRAX score because we don't have to, because we already know you're at an increased risk for a fracture because you have osteoporosis, right? But sometimes it still gets calculated. This is what is so interesting and why the FRAX score isn't 100%, right? We talked about this because it doesn't keep in mind the T-score of the spine. So when you look at this patient, wow, your risk of a major osteoporotic fracture is 18%. That's less than 20. That's pretty good. And your risk of a hip fracture is 0.8. That's really good. So, over here, this piece of paper looks pretty good. You turn the page and the t-score of a minus 2.8 points at a different picture. So that's why you kind of got to look at the whole thing. So her final diagnosis is still osteoporosis, AP spine, right? Like we talked about, specifying with a normal FRAX score, which I would just toss that out because that, in my mind, is inaccurate.